Welcome to Sutures and Stents, where Tegaderm meets Top Line and Surgiflow meets soft costs. In ambulatory surgery centers and hospital operating rooms, we talk clinical to business people and business to clinical people. I'm Mark Copeland. He's Ryan Pistone. We are Sutures and Stents. So today's guest, Ryan, you heard him. He's a very, very interesting person. Longtime friend of the show, Dr. Doug Wisor, and he's going to demystify private equity for us in a way, I had to write this down, that ropes in hula hoops and the fitness craze of the 80s, as well as the U.S. military and what wins wars. Your thoughts?
Yeah. Doug was a fascinating guy to listen to, right? Because I got to listen in on the interview. I had to write a bunch of stuff down because I didn't catch half the references. But his background and how he got to where he is today and how he kind of approaches, healthcare and private equity and kind of demystifies it for everybody is absolutely fascinating. Right. Yeah. So no, it was a really great interview.
Well, let's listen in and let's let Doug fascinate the rest of the people listening to this on private equity. This is Sutures and Stents. All right. Our next guest is Dr. Doug Wisor. Dr. Doug Wisor is the past CEO of National Spine and Pain Centers, or NSPC, where he was instrumental in growing that company to the largest private equity-backed minimally invasive spine organization in the country. When he stepped down in 2022, NSPC consisted of over 300 physicians across 13 states in over 125 offices and ambulatory surgery locations, with a top line revenue of $270 million, with a PF adjusted EBITDA of $52 million, which is very impressive. Dr. Wisor treats patients, has published research, lobbied Congress, trained physicians in other advanced procedures. He's even been featured on Fox News Channel's The Kelly File, and he's been a guest speaker at such preeminent healthcare conferences like Becker's ASC conference. Dr. Wisor now is a strategic healthcare consultant for the Williams Andrew Group, where he helps ASC leadership and doctors understand, and he demystifies private equity, value-based care, and has everybody looking at it strategically. So, Dr. Wisor, welcome.
Hey, thanks, Mark. Thanks for having me on.
Well, why don't you tell us sort of where you trained, what your specialty is from a medical standpoint?
Sure. I after graduating from medical school, I was trained at what was not then called the Medical College of Virginia, now VCU Medical Centers in Physiatry. And I was getting out of residency around 98, right when the field of interventional pain management was evolving. So back then there was barely any fellowships for physiatry. So kind of street fellowship, because I did my first 4.5 years in the Army and worked pretty collaboratively with interventional radiology, anesthesia, orthopedics, both with residents and the departments. So, kind of got my, Malcolm Gladwell 10,000 hours before a lot of people even knew what this specialty was. And what was really interesting is I started my career, I was probably going to the national meetings at ASIP and probably one of a handful of people doing this stuff in the office setting. Because I was a physiatrist, and anesthesia is the other specialty that obviously predominates in interventional pain, and they tend to be trained and spend their times in ORs, either in the hospital or the ASC. So, when these things were coming out, I was like, well, I don't understand why we wouldn't be doing these things in the office setting. So I was a little bit of a lone ranger in the early innings, but the field has caught up, and started my career after the Army. And I like to say the Army thing. So in the world of private equity, I have been labeled as what they call clinically commercial. I'm not even sure what that means, but in my mind, it has something to do with the fact that, leadership principles, whether you're leading a physician organization, a healthcare organization, or you're leading a basketball team to the Final Four. I mean, the leadership principles are the same. And, I had spent, 4+ years studying that and being commissioned right around Desert Storm. I thought I was going to go in before I went to medical school, and turned out I didn't. So I think some of those things have come along with me, and maybe that's just how my brain works. Because, I like to tell people, shock and awe doesn't win wars, logistics does, and logistics run businesses, right? So anyway,
Yeah, it's
that's
I like
story.
a couple things. First of all, I think I told you this before. Thank you for your service. Like it's appreciated. I love this term clinically commercial because that's what we're going to put you on today, right?
Yeah.
So let's talk about private equity in healthcare. I looked this up. I was talking to our producer Ryan earlier. In 2021, private equity put $206 billion into healthcare. It's something like $1 trillion over the past 10 years, so it's going up. And I'm not telling you anything you don't know, but maybe our listeners weren't aware of that. Their private equity is buying into physician practices, hospice companies, all the way up to buying Medline for 34 billion last year, which is, I mean, astounding. It's Medline, right?
Mhm.
It's an enormous player in healthcare. And you are an expert in this because you're clinically commercial. It's fascinating, and you've done this, right? You're a practitioner. So if we could, let's make it really simple for those of us who
Mhm.
aren't with the same experience. What? Let's define this. Let's make it easy. What is private
Sure.
equity, first off?
Yeah, look, I mean, it's a fair place to start, right? And it's interesting from my perspective, whether you're reading a Wall Street Journal, a New York Times article, or whether you're talking to a physician in an elevator, people have really strong emotional responses to the words
Mhm.
private equity, even if they have no idea what it means, right? Like, there's a visceral response that occurs, as we like to say. So I do try to demystify it because I've spent 10 years in a private equity backed company in the boardroom from various positions, from president and chief development officer, and eventually for 5 years as CEO. And so I've had a front row seat in the early innings, just like interventional pain management, before it was kind of, the thing that was going around. I was in the early stages of it. So it is what its name implies. Private equity is for investors to invest in privately held companies. So keep in mind that less than 1% of all U.S. companies are publicly traded,
Mhm.
right? So what private equity does is they go around and they raise funds, typically in a 10-year increment. And they may raise it from pension funds, like from the Firefighters Union or the Teachers Union of Pennsylvania, or insurance companies, university endowments, the Metropolitan Museum of Wealth, Sovereign Wealth Fund. They raise capital, right? And let's say in the early innings, they might raise 100 million or 50 million. And as they get better than public rates of return, then the next fund, which usually starts around the middle of the previous fund, so at the 5-year mark, they're already raising their next fund. And so depending on the success, if they're able to beat the rates of return, then they're going to raise bigger funds. And so usually, like they can be north of $1 billion fund. And look, let's be clear. There's a lot of financial engineering that goes in the terms of beating market rates. But if you look at the stock market over 100 years, right, maybe it's returned less than 7.4% annual rate of return. Private equity likes to use the term internal rate of return, IRR, in a fund. And the better their IRR, right, the better their next fundraise is going to be. And then they may pick areas to be experts in, whether it's healthcare, whether it's, private equity funds that just does device companies or pharma, or they might, invest in energy or other sectors, right? So what it does is it allows these institutional, endowments and pension plans to get better than 7.4 return. So it's part of a balanced portfolio for these fund managers.
Well, so then let's go from there to why is healthcare seemingly becoming so attractive to private equity, right? You said you were in it
Yeah.
before a lot, and it's clearly escalating up even through COVID. So,
Yeah.
what is it about healthcare?
Well, look, I mean, this is the old Jesse James principle of why rob banks, right? Because that's where the money is. If you look at U.S. healthcare spending, in 2021, healthcare topped 4.3 trillion with a T dollars, and that's over 18% of the GDP,
Yeah.
right? And we're quickly racing towards 20% of all U.S. spending is in healthcare. And let's be brutally honest, right? There are a number of reasons, but healthcare in its current state is broken, right? And it's quickly becoming, in my opinion, like the airline industry, which is probably why a third to half the docs, depending on what survey you read,
Yeah.
plan on either quitting or retiring in the next 2 years, right? And so the dilemma is twofold, right? The first one in healthcare that makes it so uniquely broken is 5% of the US population is accounts for the half of the $4.3 trillion spend, right? So, ask yourself, like, how much of my family really spending on healthcare, right? We don't have a healthcare service problem. We have a healthcare cost problem. And it's because such a minority drive an exorbitant amount of the healthcare spend.
Could you
right?
repeat that? Did you say 5% does half of that? I've
Yes.
never heard that before.
Yeah. So the average, Medicare beneficiary who's in the 50% might spend 11 grand a year, but the one in the 5% spends about 111,000 a year, right? So it's a disproportionate, again, and there's people with chronic renal disease and diabetes, and these are expensive populations to manage, to be clear. If you're on dialysis and stuff, some of it, no fault of your own, and some of it is, poor lifestyle choices. But either way, we have this minority of people spending an exorbitant amount of problem. That's problem one. Problem two is what I like to call the pig and the python, right? So we've been setting out to reduce healthcare spending for decades, right? Dating back to Clinton, and, Hillary was going to reform it, and then Obamacare. The bottom line is healthcare has been racing exponentially in its spending despite everything we do. And well, why is that? Because baby boomers have driven every industry that is age relevant. So, for example, they drove diapers and hula hoops. They drove suburban sprawl and two-car homes. They drove education. They drove fitness in the 80s. And now 10,000 people turn 65 every day in this country, right? And 60% of your lifetime spending in healthcare is after the age of 65. So it's a math problem, right?
Yeah.
We're not really doing anything right now in the name of reform other than trying to curb the spending curve. It's really the pig and the python. It's just a bolus of people who are in the most expensive time of their life, and less younger people feeding Social Security and Medicare. And so you have a math problem.
And so that's where the dollar is. And that's where private equity is looking to invest in vehicles that are in that space, right? I mean, I'm probably mixing my metaphors, but okay. So let's narrow it down to a couple of things you and I talked about. Ambulatory surgery centers. We see so many procedures being shifted to ambulatory surgery centers, oftentimes because of CMS, changing reimbursements to drive patients to those. So, and you had mentioned to me before that PE is also very attracted to orthopedics, which I think we now have a better understanding of why, and cardiology, which I think also makes sense based on what you just, some of the statistics. But they're attracted to them, but like, what do they do with them? How do they take advantage of that, right?
Sure. I mean, your question to me was specifically, why are ASCs attractive, right? And I don't care if you're an investor or you're a gambler. There's an old saying that says the trend is your friend, right? So said differently, we can hand wring all we want with lobbyists, but CMS can no longer afford to pay for the higher site of service differential for performing elective outpatient procedures, but at inpatient hospital, HOPD departments. Yeah. So the day of reckoning's here. I think what CMS is clearly going towards is site neutrality, which is we don't care where you do this surgery, but we're not going to pay you a tax of 25% to be done at the hospital.
In the hospital. Right? Yep. Okay. So to simplify it, CMS wants as many procedures as they can likely to move to ambulatory surgery centers, if for no other reason. There's two probably, but if no other reason that they cost less, it's the same procedure. And the outcomes may actually be even better, but if nothing else, the primary driver is cost, right?
Sure. Yeah, I mean, we'll get into that a little bit, because you had some questions about value-based care and these terminologies, But when it comes to musculoskeletal and cardiac disease, right, they've been the cash cow of, in air quotes, nonprofit hospital systems, which is a whole nother thing, right? Does anyone think the PGA or the NFL is really not turning a profit? So let's be real honest, right? Again, about financial engineering, it happens everywhere. So if you're like, well, these private equity bastards are, managing the scorecard, well, so is your hospital system. Give me a break, right? But either way, when I was in med school, right, the cardiothoracic surgeon was the cash king of the jungle, right? That was the most important person in the hospital. And then interventional cardiology comes along, and image-based, ways to address disease. Also when I was in med school, you had two choices when you came into the ER with a acute MI, right? We're going to give you aspirin and hopefully this is a small MI, or geez, this seems like a biggie. Let's go ahead and crack your chest open and reroute vessels. And so with interventional cardiology and minimally invasive approaches that are image guided, CT surgeons went to the bottom of the funnel, right? I mean, you need less of them, right? And they have maybe a little bit less clout than they used to, but they were replaced really quickly by the spine surgeon, right? As instrumentation became all the rage, right? And that was in my backyard with Hal Matthews in Richmond. It became the darling, right, of sophomore organic, and like we wouldn't even get into the data on instrumentation versus the old way of doing things. But the bottom line is the spine surgeon was the primary driver of revenue. And, and that's been driving decision making. But beyond Medicare going broke, now consumers have higher deductibles, higher copays, and they need to have a little bit of transparency on the site of service costs. So now what was unthinkable a few years ago, multi-level fusions, even lumbar, where the patient spends a night in the hotel next to the hospital, with a nurse on call and gets sent home. And I think that's obviously predicated on more minimally invasive approaches and robotics, but also longer acting anesthetics. So you don't have to be sitting in a hospital just for pain management.
Right.
So either way, look, everything marches to the lower cost setting, and that's right in the wheelhouse of cardiology and spine surgery.
Yeah,
right?
and all orthopedics actually, right? It's going that way. So private equity is interested in that because they want, just like everybody else, they want to have their hands in that because that's where money's going. Man,
right. We like to call that mix of both patient demographics and need for services secular tailwinds. There's very attractive secular tailwinds when it comes to ASC care and healthcare in general.
I'm so glad we're recording this because you're saying you have so many great terms.
These are buzzwords. You're going to sound really smart at your next board meeting. Trust me.
Wow, I'm going to have to steal all this stuff. So, hey, so we were talking about like why private equity is attracted to it, and then value-based care, right?
Yeah.
So value-based care, could you define that a little bit? Because it's a term that I think we all know. Again, like private equity, we all know. We all shake our heads, oh yeah, value-based care. None of us know what it is. None of us.
Yeah. Well, look, I'm going to make it easy, right? If you were listening to Charlie Munger, and he was talking about EBITDA, earnings before interest, taxes, depreciation, and amortization, he would say that's code for bullshit. Like that. And I like to say that quality metrics or value-based care is code for it costs less money, right? Let's just be honest. Like beyond patient satisfaction, right, there's less rehospitalization rates and infection rates, but most specialties like pain management, it's all about, are you less expensive than the alternative, right? That we were going to call that, quality. Well, we finally just said, look, this quality is kind of a BS, not, terminology. So let's call it value because at least it's being more honest, which is like, hey, what am I getting for my money?
Yeah, right. Exactly. I had a spine surgeon teach me that one time. He said, Mark, because value is outcomes divided by cost. I remember him like saying it to me, and I remember thinking like, well, that's a really simple definition that I had not heard before, but it's absolutely the case. I still don't know how you come up with some of those numbers.
But value-based care, right, the way to think about value-based care right now is primary care groups are finally getting consolidated and big, and they're going at risk, right? And they're entering these Medicare Advantage plans. Yeah. So let's say they treat a Medicare population, probably 60% of those have means and have a supplemental or, a Medicare Advantage plan.
Right.
Those are set up to share the savings with primary care. So if they can truly gatekeep the total spend on that population, then they can share in the upside. So right now, value-based care is really mostly primary care groups going at risk and then working with specialists who work in ASCs to reduce costs, whether it's cardiology, whether it's orthopedics, whether it's other GI. Can we get some of the low-hanging fruit of savings when it comes to just these cases were done at a hospital outpatient department, but it would have been just as easy to do it in an ASC or an office-based lab with just as good, if not better outcomes. Can we incentivize that?
and you're incentivized. So it's interesting because I don't think everybody understands this, and not every primary care office is value based. I don't believe. It seems like it's becoming more common, right? But they're starting that. What you're saying is, my primary care guy says, "Cope, you need a total knee." He or she might send me to a different place based on I'm going to get the same procedure with maybe even the same surgeon, but at a lower cost site, right? Facility, in this case, an ambulatory surgery center.
Yeah.
And
And it's
and that's because he's sharing some of the risk of that total cost.
Yeah. And another way to think about it is the way self-funded companies who self-fund their insurance, right? Like if you have more than 1,500 to 2,000 employees, most likely you're using Blue Cross and Blue Shield or United as an administrator, but it's your money.
Mm-hmm.
And it's the same motivation, right? Can we reduce the unnecessary spending just on site of service alone and get the same quality of outcome, whether it be whatever it is you're measuring, whether it be your return to work rates or infection rates or hospitalization rates?
Okay, we told you Dr. Doug Wisor was an engaging talker. I think we proved our point with that. Ryan, your first blush takeaways, initial takeaways from that conversation with Dr. Wisor.
Yeah, I mean, I'll be honest. My initial thought was thank God somebody can explain private equity to me in a way that I'll actually understand. Right? I don't have a background in finance. I don't know as much about private equity as maybe I should. It's kind of funny about the thing he said about 1% of all companies in the United States are publicly traded. Oh, yeah, no, when you say that, it makes sense. But yeah, his thoughts on private equity and why they're entering healthcare, was absolutely fascinating.
Yeah, and it's interesting how I suspect most people are like you and like I was, where we knew the term private equity. We react to it, but we really didn't know that much about it. And it's interesting, as Doug says, people have a visceral response to it. My takeaway sort of segues in with yours. You were fascinated by the actual definition of it and what it's doing in healthcare. And I was fascinated as well by how it's doing it. I mean, it's buying doctors' practices. It's buying ambulatory surgery centers. It's buying parts of implant and healthcare commercial companies. Like it's going where the money is. The trend is their friend. So I thought that was fascinating as well. Be curious to hear what our listeners are thinking about when they make comments on our LinkedIn page and on our YouTube channel. So hey, because the saying "all bleeding stops eventually" applies to both surgical patients and balance sheets. We'll see you next time on Sutures and Cents.